Morning, everybody. Welcome to the Mesothelioma UK series of interviews, which we've continued now with over the last year. My name is Lorraine Creech, and I'm Head of Nursing at Mesothelioma UK and a clinical nurse specialist in mesothelioma at the University Hospitals of Leicester. Just a little bit more about these interviews. We've interviewed many people. We've interviewed patients and carers, healthcare professionals and advocates, and many people within our mesothelioma community, and we've been really glad for the people who have given up their time to do that, because we know it's not always easy. Today, I'm absolutely delighted to be joined by Professor Peter Johnson, who is the National Clinical Director for Cancer at NHS England and NHS Improvement. He's also a Professor of Medical Oncology at the University Hospitals of Southampton. When I've looked back on his career, both clinically and academically, it's absolutely amazing. And the posts that he's held, both nationally and internationally, and the responsibilities that have gone alongside those are tremendous. And looking at his list of publications really just blew my mind in any way. I'm really glad that he's given his time to talk to us today. Welcome, Peter, and thank you for joining us.
Oh, thanks very much, Lorraine. It's a pleasure.
Sorry?
There seems to be an echo there. Is that, have we got something funny going on the sound?
I don't have an echo.
Oh, okay.
I've lost your head now.
Beg your pardon.
We've gone down to just your hands.
There we go. Sorry.
Okay.
No,
Is the echo bothering you?
No, that's better now, I think.
Okay. All right. Okay. So as I say, I'm delighted that we've been able to get our heads together and just take this forward. So would you like to give us an outline of your career, which I'm sure many people will find interesting?
Well, thanks very much, Lorraine. I trained in cancer medicine first in London at Barts as a research fellow there, funded by one of the forerunner charities of Cancer Research UK. And then I was, my first consultant job was in Leeds as an academic consultant there. And after a few years there, I took up a chair in Southampton, again, Cancer Research UK, Chair of Medical Oncology. And my interests, you tend to start rather broad in cancer medicine and then gradually narrow down. And my interests gradually narrowed down to lymphoma and also lung cancer and mesothelioma, which I treated for a long time when I first came to Southampton. And it was clear in those days that we had a huge amount to do for both lung cancer, conventional lung cancer and mesothelioma. And it was very prevalent in Southampton because of the docks where they used to unload bales of asbestos and the shipyards where they used to lag the boilers, and also the railway yards. There was a lot of railway repair shops down in the south as well. So I think we and Leeds, where I'd previously worked, were some of the biggest areas for the incidence of mesothelioma in the UK. So we started looking into that and trying to find better ways of treating it. And I carried on treating mesothelioma for a long time until I took up a job at Cancer Research UK as their chief clinician, which I did for just under 10 years. And that was really helping to set out the strategy for clinical research in cancer across all the places that Cancer Research UK funds it. And unfortunately, at that time, I had to stop treating lung cancer and mesothelioma and just treat one tumor type because there just wasn't enough space in my brain to do everything. So I haven't been involved. And in some ways, I moved out of the field of lung cancer and mesothelioma just at the time when the new treatment revolutions were really taking off. And in particular, of course, the immunotherapy, which has been a long-standing research interest of mine. And I set out to try and understand how the immune system could recognize cancer and what we could get the immune system to do about cancer way back in the 1990s, before the era of antibodies even started. And the field of lymphoma has been transformed by antibodies, and I think the field of lung cancer and mesothelioma is starting to see some of the same effects.
Definitely. It's really interesting to hear you say that you worked in Leeds and Southampton, because of course many of our viewers and listeners will be picking up, if they have mesothelioma or their families, about the incidence of mesothelioma in places like Leeds with the Armley factories and as you say, the shipbuilding and the ports along Southampton. And we are certainly finding that Southampton is taking very much a lead in researching mesothelioma, which is really interesting to see. And just as you say, I remember working alongside oncologists from the Christie Hospital with the satellite provision to district general hospitals. And the oncologists would come to us with perhaps covering, as you did, lung cancer, mesothelioma and lymphoma, or one or two cancer groups. And as it happens with the specialist nurses as well, that you start to know more and more about less and less, don't you, within your cancer field, particularly as you get a little bit older, as is my case. But you do become specialised.
I think it's really important that we stay absolutely at the forefront of knowledge, and you can only do that in a limited number of areas, unfortunately, as cancer medicines become more complex, and particularly if like me, you're spending a lot of time doing research and trying to really understand the biology of illnesses, you end up very focused on that, and such is the pace of medical advance, and such is the distance between our basic understanding and where modern knowledge has taken us, that it's a full-time occupation just to keep up. And I think this is one of the things I've noticed over the last 2 or 3 decades that I've been doing this, is that when I started out in academic medicine, in cancer research, the frontier of knowledge was kind of within touching distance, and I, having had a reasonably good kind of undergraduate education and medical training, could grasp and could understand it, could be current in the areas of cutting edge biology that I was interested in. But as the pace of this has gone up and the genomic revolution has come into play, and we can generate information so much more rapidly, and the sophistication of our scientific knowledge has got so much greater, so the kind of frontier of science has kind of accelerated away from us medics, and to hang on and to be current and credible and to understand the biology of the illnesses we're looking after is a lot more work than it used to be. And in some ways, I feel sorry for the next generation, because they have a big leap to make. And one of the things I spend my time doing is trying to talent spot bright trainees, particularly in oncology, who can help us with our research agenda, and to see how to help them get up to the forefront of science. Because if you've been in medical training for a few years, you're much more fixed on patient care and all the things that go with that. And the basic discovery science tends to have got away with you when you weren't looking. So I think it's a real challenge to help the next generation of clinician scientists to develop and to be as current as they need to be.
And then there's a challenge of communicating that back, isn't it? So that it can have, the benefit at the bedside, precision medicine, if you like.
Yes, absolutely. I mean, the changes that we've seen taking place in our understanding of the biology of cancers, unfortunately, not all cancers at the same speed. So I think mesothelioma is still one where we have quite a long way to go in terms of understanding exactly what the processes are and what the targets for treatment might be in the tumor itself, in a way that we've managed for things like breast cancer and lung cancer. Is still a huge challenge for us, and there's lots of different reasons for that.
So you had all those challenges, and then what led you to come on to be the National Clinical Director for Cancer?
Well, I've always been very caught up in the clinical service and how to organise that. And when I was working at Cancer Research UK, apart from trying to help to devise our strategy for research, I also did a lot of work with our policy department, thinking about how cancer services could and should be organised, and how the relationship between something like a big research funding charity and cancer care should work. And towards the end of my 10 years at Cancer Research UK, the new cancer plan came out, and Harpal Kumar, who was the chief executive at Cancer Research UK at the time, was the chair of that. And that then led on to, of course, the long-term plan. And all of these things seemed to me like they were a good opportunity to get involved in trying to help sculpt how we develop cancer services in the future. And one of the things which I think has shifted in the last decade is where we concentrate on making progress most in preventing people from dying of cancer. And a huge amount of cancer research rightly has been concerned with understanding the biology and devising new types of treatment, um, radiation treatment, drug treatment, and so forth, new forms of surgery for people with advanced cancers. But also, if you look at it, if we can diagnose it earlier, if we can pick it up at a stage when it's more curable, I think there's a recognition that that's what's going to drive the biggest changes in people's chances of survival. Um, and being able to do even the treatments that we've got at the moment at the best possible point in the course of someone's illness will help us enormously. So and I think that's become a more dominant priority, and it was certainly something we were thinking about very carefully at Cancer Research UK, and have started up a huge amount of research into early detection and diagnosis as a field of research. But also, it was clear to me that in the NHS, we needed to do everything we possibly could to make it as easy as possible for people to be diagnosed. And if you work in oncology as I do, you're at the end of the line. By the time somebody comes to see me, we already know what's the matter with them. But I know my colleagues in primary care and in medical specialties where people with cancer may come, it is enormously difficult. And if we look at what we've done over the last 10 years with, for example, the urgent cancer referrals, the number of those has gone up and up and up. And I think we see about 2.4 million people a year with a suspected urgent cancer referral in order to find cancer in about 6 or 7% of those people. So we're seeing huge numbers of people being referred in with all the anxiety and worry that entails. In order to find that small number of cancers. So finding a way to do that better, finding a way to identify people at an earlier stage so that we can treat them most effectively, felt like an important priority. And that was really what took me to working for NHS England.
Mm-hmm. I understand that. And so moving on to the tsunami of COVID-19, and what do you think have been the biggest challenges of COVID-19?
Yes, so our plans for getting early cancer diagnosis going and accelerating rapid diagnostic pathways and doing all the things that we had in mind were obviously really affected by this sudden complete upheaval in healthcare. And at the beginning of the pandemic, it was clear that this was a very dangerous infection, and that it would be particularly dangerous to people with cancer whose immune systems were weakened by the illness or weakened by the treatment that they needed. And so our real priority at the beginning was to keep people safe and to prevent them coming to harm, to shield as far as possible people who are having things like chemotherapy or radiotherapy, or who had problems with their lungs, which we knew were the main place to be affected by coronavirus, to try and keep them safe. And of course, at the same time, to try and keep cancer treatments going, even while the NHS was dealing with these huge numbers of people coming in with COVID infection and needing intensive care. And so we very quickly started to think about, well, what do we need to do to make sure that we can keep cancer treatment going as far as is humanly possible and as safely as possible? And of course, all treatments and anything in medicine is a balance of the risk versus the good that you can do. And if the risk suddenly goes up hugely because there's this lethal virus around, then the balance needs to be rapidly recalibrated, which was what we did. And of course, people took to heart the idea of protecting the NHS and staying at home. And what we saw in April and May of last year was a huge drop off in the numbers of people going to see their GPs who might have had the symptoms of cancer. And for something like mesothelioma, of course, that was particularly strong, because the symptoms of coronavirus, breathlessness and a cough and pain in the chest and so forth, are very similar to those of mesothelioma. So we did see a big drop in the numbers of people coming forward, and we very rapidly had to go out and say, look, we still want to see you. The NHS is still here for you if you've got symptoms which might be in some way related to cancer. And we've started a lot of public information campaigns, and those have got stronger and stronger as the year has gone on. And the result of that, and I think, is that in the second wave of infection that we saw just early in the new year, we saw much less effect on the numbers of people coming forward and on the numbers of people coming through for treatment than we had done in the first wave. So I think we've learned a huge amount. We've obviously been able to adapt the way that care is given in hospitals in lots of different ways to keep people safe while we do the diagnosing and the treating. And at the same time, I think I hope, encouraged people to keep coming to see us. Much more difficult than previously. Very little has been normal in the last year. And of course, a lot of consultations in primary care are still over the phone or by video, which again has lots of challenges for people. But as I say, I was pleased that in the second wave, the referrals kept going and the treatments kept going in a way that had been much more difficult in the previous year. So in fact, I think over the sort of period of March last year to January of this year, we've seen almost the same number of people with mesothelioma that we would have expected to see in a normal year. I think the normal numbers of people coming forward is around about 1,300 people a year, and we've seen very, very close to that in even during the pandemic, which is obviously very encouraging. But it has been a very worrying time, and a lot of people's treatments have been changed and done in different ways than they would have expected.
I think we've been concerned about late diagnosis, as you said, people presenting later, and then in some cases to be more unwell, and obviously the push to get them onto treatments as soon as possible has been a challenge, hasn't it?
Yes, absolutely, and we've adapted a lot of the ways that we've worked, and one of the good things we managed to do was quite early on to bring in some new drugs which we thought might be effective for treatment, or there was good evidence that they would be helpful, but which were not so dangerous to people's immune systems, for example. So we've used these checkpoint blocking antibodies, which help the body's immune system to lock onto cancers. A drug like nivolumab, which we had some evidence was helpful for people with mesothelioma, and we brought forward a rapid approval for that, so that several hundred people were able to have that who wouldn't have otherwise been. And again, I think we're starting to see some of the research evidence coming through that those types of drugs and using the immune system is a treatment that's increasingly effective for mesothelioma.
Yeah. And so those campaigns that were led, they were help us, help you, and also the do it yourself campaign, weren't they, to refer yourself early if you had symptoms, really, to make sure that you got the help as soon as possible.
Yes. So although overall we've seen more than 250,000 people since the pandemic started for cancer treatment, that's still quite a few less. It's about 37,000 less people than we would have expected to see. So although we've seen about the normal number of people with mesothelioma, there's other types of cancer where we've seen less people coming through, and mainly that's some of the much more common cancers such as prostate cancer and breast cancer, where either because the screening program was very disrupted, or because people weren't able to see their GPs as frequently, we haven't been seeing people coming through. Now, many of the people that we haven't seen have got slow growing types of cancer, which are often picked up at a very early stage. So I think we will be able to find them and treat them. But as you say, the worry was particularly during the time when the coronavirus was affecting large numbers of people, that people were staying at home and getting ill with cancer when they might have otherwise normally been able to get help and to get treatment at an earlier stage. We've just started to look at the information on the stage at which people's cancer has been found, and the data up to September last year, which is the most reliable data we've got, shows that we haven't seen more people with late stage cancer, and of course we saw less of all stages, but the ones that really dropped down were the early stage cancers, and the late stage cancers have come through in pretty much normal numbers towards the tail end of the year. But obviously we are very worried about that, and that's the reason for running these campaigns, to try and make sure that people really do know that we're serious about helping them, and that if people come forward with symptoms, the NHS is there for them.
We've ran a couple of surveys during last year. The first one, Mesothelioma UK, the first one was in April with mesothelioma patients. And the second one was with our mesothelioma clinical nurse specialist in August. Um, and with the help of our mesothelioma research centre at the University of Sheffield, there's just been published about those two surveys in the Journal of Nursing Practice. Cancer Journal of Nursing Practice. And, the findings do show that people with cancer in general, particularly perhaps illnesses like mesothelioma, that people were disproportionately affected. And I think that was always going to be the case, wasn't it? Both, physically and psychologically, because of COVID-19, really, and how they were not only dealing with the illness that they already had, but the fears and the concerns about COVID-19 as well, and what was the biggest threat to them.
Yes, and of course, mesothelioma is a type of cancer which tends to affect people whose lungs have been damaged over the years by all sorts of things, and particularly by asbestos. And if your lungs are already damaged to a certain degree, the idea of a serious respiratory infection that's very contagious is absolutely terrifying. And we know from looking at the data about the risk of people who get coronavirus ending up in hospital, or being very ill or dying from it, is much higher for people who have damaged lungs, and particularly people who have lung cancer or mesothelioma, and it's a much more dangerous infection for them. So completely understandable that people would feel very threatened by the virus and by everything that was going on, and very reluctant to do things like go to GP surgeries, go to hospitals, and potentially, to their way of thinking, put themselves in harm's way. So I think reversing that and making clear to people that we've gone to a lot of trouble and have got safe pathways and have got ways of looking after people which will keep them safe at the same time as we can effectively treat their cancer is incredibly important. And a huge amount has changed during the last year, and we, as I say, have learned a lot about how to deal with this, how to manage in the face of this threat. And I hope as the numbers of coronavirus cases go down, that we will be able to get back on track and to get our services going again.
Mm. My next question was going to be about your aspirations for the future, but I think you've probably touched on those and covered those, unless there's anything else you'd like to add.
Yeah, I think as well as having learned an awful lot about how to manage and how to help people in the face of a lot of threat, the other thing we have seen is that we can make progress very quickly. We can do research very quickly, as we've seen with the coronavirus trials, and we'd like to take some of that into cancer treatment. But we've also found that we can look after people in different ways. We can look after some people with some remote consultations and telephone and video, and I do my weekly clinic still, and quite a few of the people I look after, we have a phone call or we have a video call. It doesn't work for everything, and it's really important that we don't get carried away with that, and that we retain that ability to see people face to face, because there are some things which you absolutely have to see somebody in person to deal with. But we have over the years had many people sitting around in hospital waiting rooms waiting for consultations, which actually probably could have been done much better in different ways. So I think we've learned a lot about how to look after people in ways that suit them much better. We've learned a lot about how we can bring new drugs into treatment more rapidly. And I think we've, I hope, found different ways to speed up the things like the process of diagnosis. And one of the plans we have for the recovery of cancer care is to really power up our rapid diagnostic pathways, And there's a huge amount of thought and investment indeed going into how we increase our diagnostic capacity, because we knew before the pandemic hit that we were really up against the limits of our capacity for things like CT scans and biopsies and so forth. And there's a huge amount of effort now going into making sure that what we've got is the capacity for finding and looking after the people that we haven't seen, but also making sure that we're on a firm footing for the future.
Yeah, that's really good. At Mesothelioma UK each month throughout the pandemic, we've held a Facebook Q&A and a Facebook live session, obviously questions posted during the Q&A or before. We've been able to tell people about our updates from NHS England and also our linking in with Cancer 52, the umbrella charities for rare and less common cancers. And as a charity, Mesothelioma UK have really benefited from those charity updates because they've given us information and they've allowed us to be a conduit, if you like, to get the messages out to people with mesothelioma and their patients, their carers and families. And so that's been really helpful. So I'd like to thank everybody involved with that because we found it.
Yeah, I think it has been a very positive aspect of all this, is that as we've all learned to do this business of staring at a computer screen as a way of communicating with each other, actually we have been able to talk to each other in a much more real-time way than was ever possible before. And I think the way the community of people with an interest in cancer, whether it's cancer research, cancer care, all these different aspects has come together. And I have had a huge amount of help and input from people across the charities, from different parts of the NHS, from all the cancer alliances across the country, where when things were bad, we were doing weekly calls with all those different groups, which has been incredibly helpful for me to know what it feels like and what's going on. And also for us to be able to put out the messages about what we were trying to do. And so I think that level of coherence and interaction with the cancer community has been great. And where previously we all had to get on a train and traipse off to a meeting in London, and we only wanted to do that once in a while, we've been able to interact very, very regularly and very freely with lots and lots of people who otherwise it mightn't have been so possible to talk to. And I think that's something we're going to take for the future. I'm very keen that we continue the dense interaction with all the different charities who help people in so many different ways and have this really good feel for what it's like to have any particular illness and what it's like to go through the process of diagnosis and care, and what the priorities are for people with these illnesses, so that we can try and make sure that the NHS attunes itself to what people need. And we're continuing to do a lot of work, for example, on the after effects of COVID and the psychological effects that it's had, the changes to people's treatments and how those have affected them, so that we can learn as much as we possibly can from what's gone on.
Yeah. I also think that the multidisciplinary team meetings have benefited as well. You know, before the pandemic, we had the wranglings of video conferencing, which were quite complicated in many ways, particularly for regional multidisciplinary team meetings, which is often the case in mesothelioma. That it does seem to be more streamlined with the use of Teams and other online formats of meetings. So there has been that benefit as well, I think.
Absolutely. I think a lot of routine care has been helped by the huge leap forward that we took in technology, and certainly the multidisciplinary team meeting that I do every week is now all on this online. And I can still see and talk to my colleagues in pathology and radiology and the other oncology specialties, but we don't all have to sit in a room together. And in some ways, it probably has made us a bit more efficient, and it's probably made the discussions a bit more focused. I think there are pros and cons to this, and I think these things work really well when you know the people you're talking to on the meeting. For the future, we're obviously going to have to find different ways to make sure that we understand each other, because there isn't much room around the margins of things like video conferences for chatting to people, for getting to understand what makes them tick, and for exploring new ideas. So we're going to need to build that in. But in terms of the delivery of care, I agree. I think it's made it very much more efficient and effective.
I'm really grateful to you for joining us today. I've probably taken up much more time than I said I would do initially.
That's a pleasure.
But thank you so much for joining us, and I'm sure that lots of people will find this interview very helpful. And
Well, thank you very much. Thank you for everything you do for people with mesothelioma, and for all the support and the help and advice and input that you've given us throughout the pandemic, and hoping for better times ahead as we move into spring and the vaccines go out, and hopefully we don't see the virus coming back again. I think there are lots of positives to take from what we've been through. And as I say, the links to organisations such as Mesothelioma UK have been one of the big positives for me.
Well, thank you, Peter. Thank you for your time. Thank you for your expertise and for everything that you do.
Thanks very much.
Bye-bye. Bye-bye. Bye-bye.